This is Going Under, Anesthesia Answered with Dr. Brian Schmutzler. I'm Vahid Sadrzadeh. We're brought to you by, as always, the Butterfly Network.
All right, I'm going to let you in on something that's completely changed the way that I practice. I've been using butterfly probes for years. It's a portable ultrasound that plugs into your tablet or smart device, so I can start scanning at the bedside in seconds. If you've used the older versions, or even if you're new to the handheld ultrasound world, let me tell you why this new IQ3 is a game changer and really impressive. First off, having an ultrasound that literally fits in my pocket allows me to move faster, whether it's vascular access, procedural guidance, or just getting real-time insights from my patients. And the tech inside this tiny device is pretty incredible. Biplane imaging lets me see short axis and long axis simultaneously. Huge for procedural guidance and honestly a great tool for learners. The new out-of-plane preset shifts the scan plane digitally so I can see the needle tip sooner, which makes a real difference when precision matters. And the image quality, honestly, this little device holds up to the bigger cart-based systems and probably actually even better. That's impressive for something this portable. If you're looking for a device that supports your practice, I can't recommend the Butterfly IQ3 enough. And right now, they're running a special offer. You can get $750 off the latest IQ3. Check it out at butterflynetwork.com. And I think you still have to use the Brian25 code to get that.
You want to use the Brian25 code.
That's right. Use that code.
I see a couple things today. I see you got an olive tree behind you. It's pretty nice. Little olive tree. Not a Christmas tree. Yep. Fake olives, though.
Oh.
Yeah, you can't.
I love olives. I was going to pull one off and eat it.
That'd be olive tree right in our studio. That would be awesome. And who wore it better, folks? Him with the Fabletics or me with the raspberry? They're a little different.
Yeah, mine's just berry. Yours is raspberry.
That's right.
Yeah.
That's right.
Nifty.
Nifty.
Hey, update from last time.
Yeah.
Dr. Vasco is still alive.
Okay, good.
I have not gotten a chance to email him yet.
Okay.
But I will email him.
I think he's going to be on the podcast this season.
I'm hoping.
That'd be awesome.
I'm hoping.
Learn a little bit about Brian Schmutzler.
Yeah.
Without Brian Schmutzler interfering. Just let the facts talk.
No. We're not doing
Nothing
that.
sketchy?
No, we're not doing that.
Oh, really?
We're not doing that. No. I'll be directing. I'll be directing that conversation.
I want to know about a young Dr. Brian Schmutzler. Okay, we're gonna try these chips here.
Oh,
first.
sure, yeah. Try a masa chip. Yeah.
All right, you got all your things today.
So masa. Yep. They sent me some free chips. So my kids went through most of them. I tried some of them, but then my kids finished all of them because they loved them that much.
They smell good.
They're very good. Yeah.
What is this
So
flavor?
this is my second round. This is churro. Thank you. This is churro flavored. Probably my favorite is the cobanero, which is like a mix of a bunch of different spices and peppers and
these?
stuff. Yeah. Oh no, not these. These I bought. They sent me 2 bags of these, and the kids ate them both.
Okay.
So very crunchy, and they don't use any seed oils. It's beef tallow. So it's just corn and beef tallow. There's like nothing in them if you read the ingredients.
About 9 chips per serving. Mm-hmm. All right. Sweet. These are delicious.
They go great with the liquid death, too.
Who is not a sponsor yet, but we're hoping to get him on
Correct.
As a sponsor.
Yes.
All right. Well, today we are talking about the opioid epidemic.
Yep.
Epidemic. Be careful not to call it a pandemic.
It's only in the United States, so it can't be a pandemic. Nobody else in the world uses opioids.
Well, let's talk about that. So, I mean, again, you studied this for years, PhD in this field. We talked last week specifically about a new drug that's coming on the market that you hope will lessen the use of opioids by anesthesiologists and doctors.
Definitely.
Altogether. So let's talk about opioid epidemic.
Yep.
This has been a hot topic for years.
Yeah, a long time.
So why is it that the United States, because you just said it, why is it that the United States has a problem?
I mean, in a word, corruption. So we'll go through the whole process here of what happened, why opioids became such a big thing in the United States, how it was propagated, and then all the shady things that mostly Purdue Pharma, but also a lot of other companies did in the late 90s, early 2000s. So just going back, we talked a little bit last time about the differences between the types of pain. There's really 2 types of pain: inflammatory pain and neurogenic pain. Opioids treat neither. opioids primarily work by making you not care what's going on. Okay, right? So you're not treating
the actual problem.
Correct. You're not treating inflammatory pain with an opioid. That's an anti-inflammatory, like we talked about, Toradol or ibuprofen or something like that. Neurogenic pain, you're going to treat that with either, not causing the problem in the first place, or you'll treat that with medications like Journavx or gabapentin is an older one, gabapentin, pregabalin, those medications that actually stop the signals in those neurons. So those are the two things that are actually treating the pain, treating the problem. The best thing you can do, in my opinion, having studied this in the lab for years, is prevent the pain from happening in the first place, right? So preemptive analgesia. So that's what we do when we do regional anesthesia. I numb that nerve up before it even has a chance to send that signal to the brain.
So walk me through that process. So if I'm a patient, I check in.
Yeah.
You come in first before the surgeon.
Mm-hmm.
So I'm having let's say our good friend Dr. Adam C.
Hip replacement.
We're doing a hip replacement.
Yeah.
I come in. Yeah. What are the steps that you take?
Yeah. So you come in and we'll do what's called a numbing block or regional anesthetic. So for a hip, we do a fascia iliaca and a fascia lata. Those numb up the nerves that control the sensation to the hip. So we numb that up so that those nerves don't get the chance to send signals to the brain, and then the brain go from acute pain, hey, my hip hurts today, to chronic pain, hey, my hip hurts all the time. So there's pretty good data for preemptive analgesia when you're talking about doing regional anesthesia, when you're talking about doing numbing blocks. So that's probably the best way to treat pain, right? Prevent it from happening in the first place. From there, though, there's not a whole lot of great ways to treat chronic pain. Acute pain is probably easier to treat than chronic pain, and we do a lot of multimodal things. We do the anti-inflammatories. We do the gabapentin, where we shut down the nerve transmission. We do stuff like IV Tylenol, which works at the brain level and may actually prevent conversion of acute pain to chronic pain. But this is what I studied. I studied a very specific molecular mechanism of how acute pain turned into chronic pain. But we studied why nerves go from sensing pain in the correct way to sensing pain in an aberrant or pathogenic way, right? So having chronic pain is not normal. Chronic pain is an abnormal functioning of the nerves. So, all right. So opioids have been around for, thousands, centuries, maybe thousands of years. Opioids come from the poppy plant. I think most people know this, and we won't delve into it too much, but basically, in the Middle East, they discovered that if they took this poppy plant and they sort of, shredded it apart with their hand and sucked on it, that it gave them some pain relief, that it gave them sort of a very mild high. So direct opium.
Right?
Yes,
that was
opiate plant. Yeah,
right.
Yeah. So direct opium, if they just kind of sucked on those either seeds or leaves.
And you can smoke it too, right? You can put it in a pipe or whatever.
But they weren't really doing that. All they were doing, they would walk through the fields, grab the opium, and put it in their mouth, right? So they got tiny, tiny, tiny doses of basically the precursor to morphine. Okay, so that's been around for thousands and thousands of years. In probably
how do you even discover that? How do you even discover that plant?
Well, how do they discover anything? How'd you go to an olive tree and grab an olive off there and be like, no, this looks great, right? You don't know, right? I'm sure they're just walking through and they're like, well, I'm hungry. Let's see what this does. Right. And all of a sudden they were like, hey,
I feel good.
I feel great. And my lips are numb. So obviously something's happening.
Right.
No, I'm just kidding. Yeah. So, if you look at then the kind of around when the hypodermic needle came around, right? So the hypodermic needle is like that open-ended needle, is when they kind of were able to move from, some smoking of opium, mostly just the eating of opium, to actually converting it into a liquid and then eventually into morphine that you could inject. And so they used that quite a bit during the Civil War, right? Because that's when the hypodermic needle came around. You had syringes, so they would inject people with morphine so that they could do things like cut off legs and arms and all that sort of stuff. Probably, in terms of addiction, probably a good thing. Most of those soldiers died. If you gave them opium or if you gave them morphine and you cut off their leg, usually they died. We didn't have great antiseptic technique. Surgery in Civil War times was very, very dangerous. Yeah. So so there was not a whole lot of addiction then. Coming into the early 1900s, even into sort of the mid 1900s, you had all of these chemists working on synthetic versions of opioids, right? So not only did you have morphine, which is sort of a more natural version of an opioid, now you were moving into things like heroin, where you would take it and you would grind it up. You're moving into even the synthetics that you hear about now, fentanyl, and that sort of area of medications. And then when the pharmaceutical companies came around, they turned it into pills too. So now you also had some of these pills. The most common were morphine pills, but you also had hydrocodone pills, oxycodone pills. Those
people actually prescribe those.
Yeah,
I mean post surgery or
so
whatever.
it was almost exclusively for acute pain. You're talking about giving these medications. You've had surgery in a hospital, and they give you that medication in the hospital, and you go home and you don't take it after that. So I would argue that the stage was set with the wussification of America, right? So you've got the baby boomers, and we talk about this a lot, I know, but you got the baby boomers in the 60s. You've got this like big transition in the 70s where everybody's, whiny about everything. And then the millennials come along and everybody has to get a, trophy and blah, blah, blah. And so we, as a society, became very basically unable to deal with pain. Okay, so more and more people, even before Purdue Pharma came along, and we'll talk about that, even before that, we had lots of people who were starting to ask for, pain medication. Oh, I hurt. I don't want to hurt. And the expectation used to be, after surgery, you will have some pain.
Is this genetics though? Is my question no. Is it like the evolution of?
No,
it's just people just being
just not. We've created a society where the expectation is to never have any pain, never any physical pain, never any psychological pain, never any. I don't want to be sleep deprived, right? You look at as the generations have gone along, especially from baby boomer generation forward, everybody is so scared of anything painful or having to do anything hard, right? So I think the stage was set. And then over time, you've got these medications. There's companies out there who are making these medications called Contins or long acting. Okay, so you've got morphine. You take a morphine pill, it lasts for a couple hours. These Contins are slow release. So you take one of those pills and it lasts 12 or 16 hours. These are being prescribed exclusively for cancer-related pain, for patients who were essentially in pain from cancer, had no other options, and were dying. That's almost exclusively what they're prescribed for until probably the early 80s is when really a lot of these medications started being used perioperatively, post-op pain, right? But really before that, it was strictly just cancer and surgical, right? So,
and they wouldn't prescribe them for any, and they wouldn't extend it, right? Like, I mean, if you went in for surgery,
nope, you got your couple of pills in the hospital. They didn't even send people home with scripts, right? So the only people really who got prescriptions for opioids were cancer patients who were dying. That was essentially it,
right?
Okay. Then you've got, and I don't know if you guys want to watch there's plenty of documentaries about Purdue Pharma, is the name of the company, owned by the Sackler brothers, who have owned companies from like the 1920s or 30s. And they were basically a marketing firm, and they would buy up companies as a marketing firm. They were the firm that marketed morphine in the 20s. They marketed Valium in the 50s, right? You see all this stuff about all these women in the 50s on Valium because they didn't want to have to deal with life, the sad housewife Valium in the 50s. When one of the I think it was one of the uncles died, they went to split up the uncle's companies that he owned. And one of the brothers, Arthur Sackler, sort of got screwed and got stuck with basically nothing. But he got this company called Purdue Pharma just given to him. And the only thing that they made was MS Cotton, which was off patent. There was no money in it. So, and there's a whole backstory too about how like they made a bunch of money in this like sort of like fake thing to get earwax out of your
Yeah.
ears. There's a bunch of stuff about that in the 50s and 60s. But so he gets this Purdue Pharma company, and he says, well, we got to figure out something, right? There's got to be some money to be made here. So he has a chemist that works for him convert MS cotton, that mechanism, that slow release mechanism, convert it to use some other drug. And so this chemist goes through a bunch of different drugs, finally finds oxycodone, which is you guys may know it as Percocet, right? Percocet is the brand name for oxycodone mixed with Tylenol. Okay. That drug's been around for a long time too. It's
And what is, I mean, just for what does Oxy do? I mean,
Yeah.
it's just like a
it's
numbing.
it's a pain medication. Yeah, it's just like morphine, right? It's like a precursor of morphine. It goes to the
So a little stronger, but you mix it with Tylenol essentially. And
and that seems to help. Just like Vicodin is hydrocodone with Tylenol. These are all pills that have been out for a long time. Well, he finds that if he puts oxycodone in that formulation, the Contin, the long-acting formulation, that the mice or rats that he gives it to really like it. Like they really like it. So clearly there's some addiction potential. But that's great if you're a marketing guy and all you want is to sell pills. Okay? So they developed this and they put it out to market. And I think it was like the early to mid 90s. I think 96 maybe is when the drug started to come out. So they've got this drug. They know it's addictive, but they lie about it. On top of that, they're marketing people. So they're like, all right, let's create a buzz around this. How do we create a buzz around this? Well, let's make the amount of money that our salespeople can make huge. Let's give them all kinds of incentives. Let's make it feel like a party. They hired all these young, attractive salespeople
to go on the road, talk to doctors.
This is not something that pharma really did back in the late 80s, early 90s. I mean, there were some pharma reps and they came around, but it wasn't like a huge thing. The other thing he said is, let's lock doctors in. Let's give them trips to Hawaii. Let's give them, all kinds of swag.
Incentives.
Incentives, yeah. But they got more based on how much they prescribed. So this was not illegal. This was not illegal until I think it was maybe 2003 or 2004. So this is the reason that we have the Sunshine Act. This is the reason that you're as a doctor, you can't accept gifts from pharmaceutical companies and medical device companies. We've talked about this.
Yes, absolutely.
We're very cautious and we're very compliant when it comes to working with companies like Butterfly and other medical device, Avanos, other medical device companies that we work with, pharmaceutical companies that we work with. That's why I said with the Jurnavics, I'm not being paid by them, all that sort of stuff, right? So we're very cautious about it now, but then, nope.
There's no rules or regulations around any of that stuff.
Exactly. So basically what they did is they figured out a way to market this thing, and they got it huge out into the public. And then they started telling doctors, oh, give it for chronic pain. You can give it for chronic pain. It's not just acute pain. If they have back pain, give it for back pain. It's fine.
How much are they making on it?
Billions.
By doctors, by giving it to doctors. So it's the hospital system that buys it from the company, or is it
the company was giving pills to the doctors to give to patients and then write scripts that they would then go to the pharmacy to get. It's crazy. Like you look back at it now and you think, there's no way this is real. That's exactly what was happening. It's unbelievable what they got away with. So they went back to this one paper that came out in the early 90s saying that, and what they claimed was addiction for real pain was less than 1% if you took an opioid, okay? That was a paper, and it wasn't even a scientific study. It was just an opinion paper from a doctor who treated cancer patients in the inpatient setting who gave them morphine towards the end of their lives, and they didn't show addictive properties.
And what did you see when you researched this and fast forward?
Oh, I mean, they knew. You look back at all the papers now, they 100% knew that it was addictive. So, and they even used that, and they knew and there's so much we can talk about here, but they had all these pill mills in Florida where people would drive down, stand in line, they'd shoot it up in line. I mean, they were bringing doctors in and paying them millions of dollars just to sit around all day and write scripts for everybody. It's crazy.
So I've got an unpopular opinion here.
Yeah, let's hear it.
I don't want to open up a whole can of worms, but I almost feel like I have a feeling, and obviously you know this better than I do. But I have a feeling that this isn't only happening in the pharmaceutical industry. This is happening with our food processing. This is happening with a lot of things where it's big business.
Yep.
Hey, we don't care if the eggs are whatever.
Yeah, right. Yeah. Well, particularly with like dyes, and if you go back and look at the sugar industry,
right?
Like read some of those books that talk about the sugar industry in the 20s and 30s and our ridiculous food pyramid that has grains at the bottom, and you should eat all these carbs. Which
they were still giving those out in the 80s and early 90s.
Oh, even into the early 2010s.
Really?
Oh yeah, yeah. When clearly, if you look back, eating fat is not what caused heart disease, right? It was eating sugars. Sugars are inflammatory. They cause triglycerides to be developed in the body. Then you end up with heart attacks and obesity.
So I feel like most of these companies follow suit. It's big business. Hey, we're going to give you whatever.
Not this company. Not this company.
But we're going to give you...
Oh, yeah. Starburst, yeah.
Okay.
Yeah.
Hey, it's great for kids. Yeah, I mean, but you don't really know what's in there, right?
No,
I mean, nobody's going to sit there and be like, oh my gosh, you know, I did the study on Skittles, and here, I'm just saying as an example, this is the marketing.
It's worse. It's like, so they did the studies, right? They did the studies, not on Skittles, but on Oxycontin. Yeah. And they showed that they were addictive in mice and in people.
But they chose to ignore it.
They chose to hide it. Right. So it's even worse. Yeah, I mean, I get it saying like, oh, we're ignorant, so we don't know. That's not right, but it's not quite as wrong as doing the studies and then suppressing
knowing it.
it.
And then suppressing it. And so where does the
government come in?
Where does the government come into all of this?
So it's funny. The government turned a blind eye. And the Sacklers donated a lot of money to a lot of
different people.
Yep, to a lot of
campaigns.
Not directly, but via campaigns, via lobbyists. So the government was turning a blind eye. At the same time, there were societies. The American Pain Society is the classic one that was bought and paid for by Purdue Pharma. The American Pain Society in the 90s, late 90s, early 2000s said, "Oh, pain's the fifth vital sign." And if you don't treat pain the right way, you're not treating the patient well enough. And if you're not treating the patient well enough, CMS isn't going to pay you. And CMS got involved with the American Pain Society on this whole pain is the fifth vital sign. So I come into medical school during this time, right? And I know this stuff because I've studied it in the lab. And I'm like, well, why are we giving everybody opioids? This is not a good thing. We shouldn't be doing this. And I got destroyed on my evaluations by multiple staff saying that I wasn't compassionate enough about people's pain when they're coming in asking for 120, 250, 300.
These are staff members at
IU School of Medicine, yeah. So 300 pills. Oxycodone pills. Or Oxycontin pills. It's like, what? I'm not going to prescribe that. I'm not going to do it. There's no reason to do this, but pain is the fifth vital sign. So anyway, I could go on for hours and hours and hours about about Purdue Pharma and what we did as doctors prescribing these medications. We were complicit. We as physicians, and I will not include myself in this because I have written very, very few opioid prescriptions in my entire career, but we as a medical community really propagated this. It was set up by our society. It was sort of created, the medications and all the advertising and all that was created by Purdue Pharma, but without us writing the actual scripts, the medical community, it wouldn't have happened. So we're to blame too, 100%. Okay, so all right, all these people start dying. Yep. There's tons of people dying from getting addicted, dying just from taking oral opioids. Well, then they start to crush them and snort them. That kills more people. And I don't know. So we're in South Bend, Indiana. There's a foundation here called the 525 Foundation. Do you know much about them? Yeah.
Yep.
So I used to be on the board or on one of their sort of medical boards. Helped them a bit. They actually just this past weekend had their give back, right? Where you bring in your used pills and they get rid of them for you. So that family had 2 brothers die on the same night by taking some sort of pill. They don't know exactly what it was. So this is 2015. So this is way far into the opioid epidemic. Okay, so take us into maybe 2008, 2009. We're starting to realize as a medical community, oops, we screwed up. So now what do? We swing the pendulum maybe a little bit too far the other direction. We just yank all these people off of their opioid pills. So now what? What are they going to do? They're addicts at this point. So what are they going to do? They're going to go to the street corner and get heroin, right? So this first wave of the opioid epidemic was us writing pills, right? Writing
the second wave
is now we're not giving you the pills. We're going to go get heroin, right? So that's the second wave of the opioid epidemic. A lot of people either ended up homeless or mental issues or died from that wave of the opioid epidemic. So now what do? Well, we bring them into treatment, but opioid addiction is really tough to treat, really tough. More so than alcohol, probably more so than maybe anything except cigarettes, right? So opioid addiction's rough. Okay, so now let's take it to 2016, 15, 16, 17. Okay, so we know we've got that first wave. There's still some people around taking a bunch of pills. We've got the second wave with a bunch of people injecting heroin, which is still around as well. Now the third wave is the synthetics. So now you've got fentanyl coming over from Mexico, coming over from China. People who
we're in that wave still.
Still. Now people know about it more. 15, 16, they didn't really know. They just, this new drug from China, I'll just use it. And people got addicted to it. What they're doing now is they're cutting other drugs with fentanyl because fentanyl's so exceedingly cheap. Right, so they bring it over from China and Mexico. It's incredibly cheap. So you mix a little bit in with your heroin, and it's cheaper. You get to, if you're the drug dealer, you mix a little in with your heroin, and you sell your expensive heroin with cheap fentanyl in it. Yeah, some people probably die because fentanyl's way more potent than heroin, but you make more money, right? So that's kind of the wave that we're in now. On top of that, there's probably a fourth wave we're in and probably just starting. So in the United States. The FDA, you have to have the exact chemical compound for the FDA and the DEA to consider that drug a scheduled medication. So fentanyl, if you add a little bit onto the side, even if it does the exact same thing, a little bit of molecular change to it. So there's other drugs, carfentanil and alfentanil. There's a bunch of like registered drugs. But what the Chinese are doing is they're just making little tweaks and it's no longer illegal until the FDA and the DEA can catch up and say, okay, this is a new fentanyl
variation,
analog, right? So now that's illegal. But they just keep making new ones and bringing them in and bringing them in. And so that's the phase that we're currently in. All because Purdue Pharma figured out a way to sell and addict people to opioid pills.
So 2 questions before we wrap it up.
Yeah.
One, where is Purdue Pharma now?
Bankrupt.
What basically is their future if you're looking at
Purdue Pharma?
Yeah, done?
Yeah. So they paid billions of dollars in restitution. The Sackler brothers, who owned it, and some of their top executives were actually up on criminal charges, but they made a deal and just paid a bunch of money to get out any criminal charges. I mean, they should have been held accountable. They knew what was going on. So Purdue Pharma's out of business.
And what about those doctors and physicians that were...
So some went to jail. Many were never held accountable. And now we get all this training about how to safely,
that was my next question.
How to safely prescribe opioid medications. So now it's a requirement to have a DEA, which means I can prescribe scheduled medications. I have to have 8 hours of continuing medical education on how opioids work, how to prescribe, how to find addiction, all that sort of stuff.
What is the process at the hospital?
Yeah.
I just had Dr. Cian do my hip.
Yeah.
He didn't. But, Dr. Cian did my hip. You did my regional block. Afterwards, I need something.
Yeah. In the hospital or when you go home?
In the hospital. Yeah, is there like a box? Who's in charge of that box? What happens?
So most people use an electronic system. There's several commercially available ones out there. The most common are Omnicell and Pyxis. So I go in, I type the patient's name in, Vahid Sadrzadi. Okay, what do I want to take out? I'm going to take out 1 Percocet pill. It drops it out. I register that I took it out. I go take it to you. This is what the nurse does. I'm not doing this, but the nurse takes it out. They bring it to you. They chart.
And they have training as well on this.
They chart. I gave the pill to Vahid. He took it. So that's how we keep medications, under lock and key now.
Okay.
Yeah. Man. So it's interesting. So the other thing is all of the distributors. So a big one was Mallinckrodt, was a big company that was a distributor. AmerisourceBergen, all these big distributors, they were also found financially liable because they knew that they were selling and distributing billions of opioid pills, and the courts said they should have known better. They should have stopped a lot of these orders. So they were held responsible as well. What's also interesting is that this is a strictly American problem. The U.S. uses like 99.7% of the world's opioids. We are the only country in the world that isn't just like, oh, you got, you had surgery, you're going home, take Advil, take Tylenol. Yeah, I got back pain, stretch it out, deal with it, take some Tylenol, right? So we have a uniquely, the opioid epidemic is uniquely an American problem.
What is the answer? What does the future look like? What is your opinion on what it should look like?
Well, I mean,
continue to train, continue to do the right things.
Opioids for acute pain only, strictly in a very closely monitored situation. Otherwise, you should be on other medications. Maybe Journavx. Maybe there's something else coming out. Maybe it's a combination of, other drugs that we have currently. But opioids should not be used for a long period of time. Opioids should not be used as a first-line pain treatment.
Do you, in a hospital setting, do you talk to other physicians about this? Do they have, if they have a method they use? I mean, is there conversation around this, or is it kind of taboo to talk about your methods, what you use with other physicians?
No, I think we talk about it quite a bit. It's sort of faded out of, so this was huge in like 2010, 2011, 2012, because finally the medical community was like, yeah, we screwed up. Remember when you were a medical student in 2003, 4, 5, 6? Yeah, well, we screwed up what we told you then. Now that it's 2010, 11, we probably shouldn't be giving these many opioids. So yeah, I think we talked about it more then. Now it's just sort of a known thing. Like most of the orthopedic surgeons that I work with, if they give any pills at all, it's like 3 days worth of pain pills. And then after that, the patients have got to do it without. And I think in anesthesia, we're a little bit uniquely shielded from it because I don't write prescriptions, right? Mm-hmm. I mean, I give some opioids in the operating room and maybe even on the floor when I'm doing hospice work, but I don't write prescriptions. You would never come to me and get a prescription for an opioid.
That'd be your doctor or whoever.
Yeah, your primary care doctor or maybe even your surgeon. So I'm shielded from that a bit. I will say that there is a big push in anesthesia to be opioid free. We probably won't ever get opioid free, right? So giving somebody an IV opioid in the operating room is a different thing than giving them a script for opioids. So I don't really subscribe to the let's go totally opioid free, but I am very judicious on the amount of opioids that I use for patients.
Great conversation as always.
I love it.
Yeah, I mean, you are very knowledgeable, obviously, in this area, having a PhD.
Mm-hmm. Yeah, neuropharm, yeah.
We could probably talk for hours about this. Maybe what we should do, too, is get somebody on that we can talk to about, take this maybe a step further. I know we're going to try and talk to Dr. Adam Cian.
Yeah.
Maybe interesting to bring this topic up to him as well. We're going to try and get
Dr. Vasco.
Dr. Vasco on, who knows a thing or two about your college days, which I love.
PhD, but
PhD. And then we're still going to try and get Zane.
Yeah.
Dr. Hassan.
Yeah, we'll probably record him next week, I would
imagine. Is not in he's not in...
He's in Pittsburgh.
Yeah, he's Pittsburgh. He's not in L.A. anymore.
No,
right.
No, he's in Pittsburgh now.
From Minnesota to L.A. to Pittsburgh.
Yeah. It would be great. There's a couple of things. It'd be great to get somebody on who had any part in that whole 96 to 2010.
Yeah.
Like if they were a part of any federal organization or even a part of Purdue Pharma, like if there's a former rep around, I would love to have them on and talk to them.
I have to say something. The parents of who are involved
Yeah.
with the 525, whose
Yeah.
kids you were talking about.
Yeah.
They're great.
Yes.
You know, they've been an advocate for
Yeah.
talking about this for so many years.
Yeah, we could have Becky on. That wouldn't be a bad idea. Yeah.
She's wonderful.
Yeah.
I know we've talked to her in the past in the television world, and it's a great organization.
Yeah.
They do a lot of good things in our community here.
Yeah, 525foundation.com, I think, is the website if you want to go check it out. And if there's anybody out there who's listening who has any expertise in any of these issues, we'd love to have you on, and we'll do it remotely and have the conversation. But I mean, I'm clearly passionate about this. I think we made a huge mistake, and we're still paying for it, and probably will be for another generation or two. So
Trying to correct it every day.
Yep.
This has been Going Under, Anesthesia Answered with Dr. Brian Schmutzler. We are brought to you by
Butterfly Network.
Brian25 in the
Sounds
checkout. I'm Vahid Sadorzadeh, and we'll see you in the next one. Maybe we'll be wearing matching blues.
I'm not calling you next time.
See you in the next one.